Yeah, good afternoon, everybody. I'd be speaking on our experience with post-treatment evaluation of gliomas using advanced MR imaging techniques. We all know that malignant gliomas are a leading cause of CNS tumor-related deaths, and patients with GBM have a median life expectancy of less than a year, even with the most optimal multimodality treatment protocols. And the standard treatment in these patients is cytoreductive surgery, followed by a combination of chemo as well as radiotherapy. Even after these protocols, there is a high incidence of GBM recurrence after a median time of around 7 months following diagnosis, and in more than 90% of the times, it is within 2 centimeters of the site of the original lesion. Contrast enhanced MR has been used as the first line of investigation for a clinical problem focused evaluation as well as for surveillance of these patients on follow-up. The increased contrast enhancement with worsening cerebral edema and mass effect are actually the hallmark of a recurrent disease like seen in this patient with a solid cystic pattern of enhancement. However, the treatment-induced changes, which were earlier known as radiation necrosis specifically, may also occur in a given patient, which may mimic appearance of a recurrent tumor. And this would lead on to this is known as pseudo-progression. Like we see in the lower part, it is again a solid cystic, predominantly a necrotic type of enhancing lesion, again in vicinity to a site of the operative cavity, and this may mimic a recurrent tumor. So we need to differentiate between these two, and we should be knowing that there is a 30% incidence of patients treated with concurrent temozolomide, which is a standard of chemotherapy care in these patients, and radiotherapy, who lead on to develop a treatment-induced necrosis. And moreover, to complicate matters, there is a frequent coexistence of both neoplasm as well as treatment-induced changes occurring in a particular patient. And these are almost always occur in the same time interval, around 1 year to 1.5 years later after the initial treatment protocol. Therefore, differentiation between the two is clinically necessary for the better treatment approach to a patient. There have been some conventional contrast enhanced features, MR features, which are helpful to differentiate. As I've already told you, both of them actually present with necrotic enhancing lesion with edema and mass effect. However, if you see a solid pattern of enhancement, corpus callosum involvement, subependymal enhancement and spread across midline, they have been shown to be associated with more often than tumor recurrence than necrosis. And the treatment-induced changes have a classically shown to have Swiss cheese or a soap bubble pattern of contrast enhancement. So is advanced MRI, is it a viable solution in differentiating between the two? Basically, we all know that diffusion is based on the cellularity of a tumor, perfusion based on the microvascularity, and spectroscopy based on the metabolite map. And all these we'll use in trying to differentiate between the two. The diffusion calculates the ADC values, which we have all seen in the previous talks, depends upon the diffusibility of the water protons. Theoretically, in a post-therapy tumor, when there is cellular swelling followed by necrotic and apoptotic cell death, which is the classical hallmarks of treatment-induced necrosis, this will have unrestricted diffusion, therefore will have high ADC values and ADC ratios. Whereas a recurrent tumor should be having high cellularity, therefore a restricted diffusion and low ADC values and ADC ratios. In our institution, we perform the routine spin-echo EPI sequence in axial plane, and the diffusion gradient is encoded in 3 orthogonal directions with a B value of 0, 500 and 1000 to calculate the ADC values. And the visual inspection of restriction of diffusion on the trace DWI images is the first which is seen, and the tumor recurrence is seen as high on DWI and low on ADC maps. We can also calculate the ADC values by drawing the ROI, and it is typically we fuse the, in fact the slight division of our protocol is that we take the DWI axial plane in the same plane as the routine T1 and T2 axial and the post-contrast axial images we are taking, rather than a slightly different plane which is normally used for diffusion weighted imaging, axial plane. And that way we actually merge them on the 3D fusion, and we see the enhancing portions, the most enhancing portions on a T1 post-GAT sequence, and the part which is among that enhancing region is showing the restricted diffusion. We put ROI on that and try to calculate the ADC values from that region. And to normalize the ADC values, we can take the ratio of this ADC on the lesion to a contralateral same sized ROI on a contralateral normal appearing white matter, so that there is no variability in between the scanners and all. We can standardize that method. Similarly, perfusion can be done with a dynamic susceptibility weighted to calculate the RCB values. Tumors have high microvascularity, therefore will have theoretically elevated RCBV, and necrosis will have decreased RCBV. In our institution, we take the routine T2 star weighted EPI sequence after a bolus of 0.1 millimole per kg of gadolinium, maximum 20 ml, at a rate 5 ml per second, followed by 20 ml saline flush through a pressure injector. And the gadolinium concentration curve is plotted, and the area under the curve gives you the RCB values. Again, the perfusion is done in the same plane as the post-contrast T1 weighted imaging. Therefore, the RCB color maps can be fused with the post-GAD T1 on a 3D fusion sequence. And again, the ROIs can be drawn to calculate the RCB values from the enhancing portion as well as the portion which is showing you visually elevated RCBV on the maps. Again, the ratios can be normalized between the two sides by dividing it to a contralateral normal appearing white matter, same sized ROI. And according to literature, there have been lots of studies which have shown that normalized mean RCBV ratios greater than 2.6 has been taken as a threshold for diagnosis of recurrent tumor. So more than this is likely to be a tumor, less than this is likely to be a treatment-induced changes as per the literature. Spectroscopy again will display the distribution of various metabolites. Tumor recurrence will theoretically have elevated choline levels, and in necrosis would have overall decreased metabolites, including all choline, creatinine and Na levels. In our institution, we use the 3D multivoxel spectroscopy with press at T135, and VOI is localized to include the contrast enhancing lesion as well as extended to include the normal appearing white matter, specifically if possible on the contralateral side. And we obtain the choline to Na, choline to creatinine and Na to creatinine ratios. Here we go by the method of being taken the worst voxel method in terms, because it is a heterogeneous lesion, lots of areas are necrotic, but we are looking at the area which is showing some evidence of tumor. Therefore, any one voxel which is giving you the highest of these ratios should be taken, and the ratios calculated from this. Again, these can be normalized to the other side, and according to literature, choline to Na or choline to creatinine ratios more than 1.8 or normalized ratios of 1.7 are taken as threshold for tumor recurrence. I'll show you some examples which we did in our institution. This was a 37-year-old male patient, had a left frontal astrooligocytoma, operated. This was the post-operative cavity. This is the baseline MR. See, it is in 2004. There are some signal changes on the T2 weighted image, but none of them is showing contrast enhancement. So no contrast enhancing lesion seen. However, 4 years later, the same patient develops almost a solid looking enhancing lesion slightly distant away from the original site of the tumor, with some central areas of necrosis seen in the central part. The dilemma always remained that whether this is treatment induced changes or tumor. We went ahead and did the routine diffusion. It showed that there was clearly visually seen as restricted area of diffusion, especially at the periphery of the lesion, not so much in the central necrotic part, and obviously the ADC was showing it to be dark. The perfusion was done, and the RCBV is seen to be elevated in the site of the tumor, like seen in this case, and the RCB values, the normalized values were more than 2.6 in this case.